Welcome to the Tuesday edition of the MD Edge Daily News. I'm MD Edge editor Mary Ellen Schneider.
And I'm MD Edge editor Terry Rudd. Today, change is coming to recommended approaches for hand osteoarthritis.
Also today, how the right medication starting dose shapes success in treating anxiety disorders.
And later, how to avoid fraud and abuse hotspots in your telemedicine ventures.
But we begin today with when to start colorectal cancer screening. The American Cancer Society recently recommended dropping the age of first screening from age 50 to 45. But assessing individual patient risk rather than focusing on a birthday may be a better approach. That's according to Dr. Charles J. Kahi of Indiana University, Indianapolis, and his associates, who authored a commentary in the October issue of Clinical Gastroenterology and Hepatology. In fact, tailoring the age of first screening to a patient's own risk factors and preferences might improve uptake and benefit-risk ratios, they argue. Colorectal cancer rates in people younger than 50 rose by about 22% between 2000 and 2013. But Dr. Kahi notes that estimates of the most recent birth cohorts have wide confidence intervals. And the absolute risk of colorectal cancer among the under 50 set rose only slightly, from 5.9 cases per 100,000 people to 7.2 cases. The new recommendation could detect earlier stage colorectal cancer in a youthful and productive age group, assuming 100% adherence. But in reality, uptake among 45 to 49-year-olds might be less than 20%. And if those younger patients have few risk factors for colorectal cancer, the result could be many false positives and unnecessary colonoscopies. So Dr. Kahi says, think about younger patients' other potential risk factors. Those include male sex, having a first-degree relative with colorectal cancer, high body mass index, metabolic syndrome, and cigarette smoking. Also factor in diet, a patient's screening adherence, and their use of aspirin, NSAIDs, and hormone therapy.
EULAR's first new recommendations in 11 years for managing hand osteoarthritis back some new ideas and retire a few old approaches. The first big change. Backed by new research, EULAR's task force recommends not treating hand OA with conventional synthetic or biologic disease-modifying anti-rheumatic drugs, or DMARDs. The authors also advise adapting the long-term follow-up of patients with hand OA to individual needs. Base that follow-up on symptom severity, presence of erosive disease, reevaluation of drug therapy, and a patient's wishes and expectations. And for most patients, standard radiographic follow-up isn't useful. The EULAR task force prefers topical treatments over systemic treatments, and it says oral analgesics, particularly NSAIDs, should be considered for a limited duration. The authors also give a nod to the supplement chondroitin sulfate, saying it may be used in patients for pain relief and improvement in functioning. In general, avoid intra-articular glucocorticoids, though you might consider them for patients with painful interphalangeal joints. Surgery should be considered for patients with structural abnormalities when other treatment modalities haven't been sufficiently effective at pain relief. The recommendations appear online in the Annals of the Rheumatic Diseases.
The first-line meds for anxiety disorders may be the same ones used for depression, but the right starting dose strategy is quite different. That's according to Dr. Elizabeth Loudermilk, Medical Director of Outpatient Psychiatry at Denver Health. Speaking at a conference on internal medicine sponsored by the University of Colorado, Dr. Loudermilk outlined how to use the SSRIs and SNRIs familiar in depression treatment for patients with anxiety disorders. First, folks with anxiety disorders tend to need the higher doses, she explains. They just need to get there a little more slowly. The trick? It's not what drug you use, it's what dose you start at. For example, when Dr. Loudermilk starts sertraline for depression, she starts it at 50 milligrams per day. But for anxiety, she starts it at 25 milligrams. Give it a week or two at 25, then double it to 50. She then titrates over 2 to 3 months to a higher maximum dose. Response times differ too. SSRI and SNRI's anxiolytic effect seems to be more robust sooner. People start noticing something within the first couple of days to a week, and they'll keep getting better, which people love, Dr. Loudermilk says. For patients who don't experience complete symptom resolution, the next move isn't adding a second antidepressant. It's to augment the high-dose antidepressant the patient is already on with something else. Among the options are hydroxyzine, buspirone, and gabapentin. Reserve atypical antipsychotics for patients with an inadequate response to a maximum dose SSRI or SNRI. And benzodiazepines? Yes, they're approved for anxiety disorders, but Dr. Loudermilk advises against them as routine practice. They cause more problems than not. And short bursts of use aren't short, she cautions. Patients tend to come back and want more. Ultimately, what's the best approach? Dr. Loudermilk says it's the combination of medication and behavioral therapy.
And finally today, more doctors are discovering the value in treating patients via telemedicine. And following a few tips can help you avoid running afoul of fraud and abuse regulations when you're using telehealth. Lisa Mazurs, a Chicago-based health law attorney specializing in telemedicine. She says the first area of danger is improper coding. In fact, incorrect billing for telemedicine services is a top trigger for federal fraud and abuse scrutiny. Doctors know what they need to do for traditional inpatient services, but Ms. Mazur says they don't fully understand telemed's complexities and nuances. To stay safe, regularly review the Centers for Medicare and Medicaid Services resources on requirements for telehealth payments. The feds are also on the lookout for kickback schemes. For example, if a large hospital system leases telemed equipment at a discounted rate to a rural practice, the hospital could be accused of providing equipment at less than fair market value to secure referrals. But Ms. Mazur says that if health professionals can show that their telemed arrangement legitimately benefits patient care and improves patient outcomes, they're not likely to draw scrutiny. Finally, be wary with free patient technology. That includes offering patients free remote monitoring devices or apps that help track medical data. Anytime a provider who's billing Medicare for services gives something to a patient for free, there's a concern that you're trying to induce them to come to you for care. So, don't market the free or discounted product to patients. Make clear that the free products don't increase profits for your practice and that they don't increase federal health care billings. You can access all of Ms. Mazur's telemed resources by following the link in the podcast description. And that's the MD Edge Daily News for Tuesday, September 11th. The MD Edge Daily News is now on Spotify. You can also subscribe on Amazon Alexa, Google Podcasts, and Apple Podcasts. For MD Edge, I'm Terry Rudd.
And I'm Mary Ellen Schneider. If you like what you hear, be sure to rate us on your podcast app. Thanks for listening.